You're supposed to
Not
sound
exciting
a little
enough.
bit more enthusiastic, but that's fine. We'll recover, hopefully.
Hey, we're here. All right.
What's going on, everybody? Welcome back to episode 126 of the Core Consult RX podcast. Cole's with me today, as always. Also, we got two guests. Returning for probably his fourth time, Dr. Patrick Key. Patrick, what's good, man?
Hey, thanks for having me.
You're supposed
Not
to sound
exciting
a little
enough.
bit more enthusiastic, but that's fine. We'll recover, hopefully.
Hey, we're here. All right. Thanks for having me.
We also have first-year student, right, AJ?
Right.
AJ Alford is an intern at Federal with me, and also first year at MUSC, so he's hanging out with us today. So we're happy to have him here today too. This is his first time on the old cast.
Happy to be here.
Yeah, man, we're happy to have you. And so we're going to talk through some cool stuff today. But before we get started, obviously, Patrick, the world's dying to know what you've been up to.
Are they? I don't know. I've been up to a lot. Things are getting really busy. I'm in my second year of residency. We're doing really cool stuff now. They let me design my own project this year. So we're like going in and looking at which patients that have been identified at high risk for suicide have overdosable medications prescribed. And if they're prescribed over a 30-day supply, then we go ahead and we write a note on it. And we're not saying change this. You know, apparently there's a lot of liability involved. So we're just saying these meds are high risk, consider something else. It's really rad so far. I had to look up every single drug that can be provided and learn the overdose data behind it. Surprisingly, not many resources on overdose.
So, what did you like when you say every drug? You're talking literally every drug.
I spent like a week, and just like in my free time, I'd pull up my laptop, go to like PubChem or some other kind of at least tertiary resource, type in the drug name, and then look at overdose data if there was any. And a lot of time the package inserts help. There's case reports. Again, PubChem is a great resource. But I feel like if you're looking for like pregnancy, there's like Briggs. Overdose, there's like nothing. And don't say poison. Don't say poison.org. They're useless.
Well, poison.org.
No, I feel like that's the one I said.
Also, I really hope that there's no one that works at poison.org listening. So Patrick just insulted you. My bad.
Well, I contacted them and said, hey, which beta blockers are lethal in the case of overdose?
Fat soluble ones, duh.
And they said, antihypertensive beta blockers.
So I guess you just need me on your team then.
So what about poison control? What do they use? Not poison control, but when you call the guys in Columbia and South Carolina.
Oh,
you know what I mean?
I should have called them.
I was gonna say.
Yeah, I didn't. I should have called them.
Any mom knows to do that.
I could have saved a lot of time.
Yeah, you probably could have. Could have done it in 10 minutes.
I don't know about that. Anyway, everything's good. Everything's good. Just working on that, working on everything else in residency. It's a full-time job.
With South Carolina now allows, in the retail setting, to pharmacists to swap to 90-day supplies, with the caveats being controlled substances and antipsychotics. Not a lot of.
No kidding.
Yeah,
I didn't know that.
Yep. Though there's some gray area there with things that could be used for other things, but might also be being used for some kind of psychotic disorder. But anything that's definitely classified as antipsychotic can't swap to a 90-day.
So that's an interesting thing. I don't want us to get off the rails, but something fascinating.
Here we go.
Is if you look up the ICD codes for death. If you look those up, and I promise, look it up. You can try. I looked up what would they call it if you overdosed on lithium on purpose? It's called an antipsychotic overdose. And that's bizarre. And so then there's even these extrapolating things that if you overdose and then you crash your car into a tree, that's an overdose death. It's bizarre. I don't know. So there's a lot.
Well, I guess they can only have so many codes, car crash, overdose, death.
Well,
that one, code. Not a billable code.
I'm being facetious, but you could have its own code for lithium, I think, or even just call it a mood stabilizer or something instead of an antipsychotic.
So, that's what, because they're just calling it antipsychotic.
Yeah, gotcha. And it goes with the other ones.
And they have it. Does it specifically say lithium? Because wouldn't they just call it poisoning, intentional poisoning?
So it's intentional. I don't remember the exact one, but it's intentional overdose of antipsychotic or along those lines. But no, it doesn't have the word lithium in it, and it will be coded with the other ones. So it's hard to do retrospective data analysis. Anyway, we don't have to go too far down this rabbit hole.
AJ, what Patrick's doing right now is he's filibustering.
Yeah, I'm trying to make the show about.
He's panicking. He's in full panic
How
mode.
am I panicking?
I'm enjoying it.
I'm sounding confident.
See, the other thing you got to know about Patrick AJ is that he's extremely full of himself.
AJ, listeners, make sure you know that.
Tell everyone you know, Patrick. That's K-E. Look him up on Facebook.
You want to give him my address?
Sure, you got it?
No.
His address will be included in the show notes.
Please don't.
AJ, what's up, man? We have to introduce you too. Tell us a little bit about yourself.
Well, I'm from here, Charleston, South Carolina. I was in the Navy for a little bit and came back. Now
Nice.
I'm in healthcare, getting into it, really loving pharmacy. I'm still in that phase where I can sort of save the world, just be me by myself. So I'm figuring that out.
What made you go to pharmacy versus other healthcare?
So I actually got accepted into medical school and pharmacy school, and shadowing doctors and then shadowing a pharmacist. I went to CVS and sort of worked as a tech there, and I was like, I would absolutely not want to be a pharmacist at all, ever. And then 2 months later, I accepted my acceptance into pharmacy school. But between that, it was kind of like one of those things where very objective kind of guy. You know, there's different disease states and diagnosis, all the kind of stuff that goes into that. Wasn't really into a lot of that. I just wanted numbers, things that I can look at and understand and know, and that for the most part won't change very much. And that's drugs. Now, pharmacodynamics and things like that, I mean, it changes every day. But I really enjoyed a lot of the chemistry behind pharmacy, and that's why I started.
Nice. And then you meet Patrick, and you're like, "Is this what a pharmacist is like?"
Oh,
And you're
whoa.
like, there's
Whoa.
like, is that acceptance still good for medical school?
We have very similar motivations. I feel the same way. It's
really hit or
chemistry
miss.
major.
So here's, I don't know. The one thing I will say though is, as far as like staying like the same, pharmacotherapy changes literally every week. That's the one thing where it will change very abruptly, and the concepts I think will stay the same, but then the overall, that's where you do have to be like constantly willing to update and change and stuff like that. And you'll see like when you finish school, like 2 years later, your notes just be like trash at that point because most of them are completely
But I guess if
outdated.
I'm thinking of like what a doctor does day to day and a pharmacist does day to day, I guess there probably is less gray area with what a pharmacist does versus
I would say
what a doctor
100%.
does.
Yeah.
Yeah. Okay, good. We're all in agreement.
I disagree, just for the heck of it. I disagree completely.
So
Yeah, that's
Patrick's
cool.
here, which means we must be doing a women's health topic. Oh,
Yeah.
Women's
Oh.
side topic. Okay, so let's talk about contraception and their interactions with mood stabilizers. I'll start with carbamazepine. Which ones can't we use?
Dude, first of all, we've already talked about
Okay,
the
first of all, go
auto-induction
ahead.
of carbamazepine.
Okay,
You're not,
no, go ahead,
no one
go
here's
ahead.
impressed, so
No,
let's
okay.
just get off that tip.
Which ones can't we use though? I didn't hear you.
Any of the
Any.
the estrogen combos,
Okay,
you
we
can use them. You just have to be monitoring.
You can use them. It'd be wrong.
You get to use progesterone only.
Don't fall for it, Mike. Don't fall for it.
IUD is the answer.
Oh, please get out of
That's
here.
the
Yeah,
answer.
and it's a progesterone only, isn't it?
Yeah, but that's not the...
Doesn't matter. You're destroyed. AJ, I want you to know Patrick's my nemesis. He used to be my student, and now he's gotten a big head, and so now this is it. We have to fight to the death on the air every time he comes on.
If you go back and listen to all 4 episodes, you will see one antagonizer every time.
His name is Patrick K.
Okay.
All right. So we're going to be talking about schizophrenia kind of again. They all gave me a hard time because they said that I repeat topics too much, but that's okay because there's some cool stuff that came out and some new updates from the new guidelines from 2020. So
Whenever there's a new guideline, that justifies us doing it again.
there you go.
That's all
Thank
need.
you.
Yes.
It doesn't matter what Patrick says.
No,
We're doing it again.
I came over here and I said, this is a great topic. We should dive right in.
Yeah.
I said schizophrenia. You've never talked about that before.
You didn't. Okay. That's it. I'm done.
Schizo what?
Somebody mute his mic.
Okay.
All right, guys. So we'll kind of just go through we've talked about this before in a podcast, and obviously a lot of the background information hasn't changed, but we'll kind of just review some of that. So as far as, in Patrick, throughout your residency, have you dealt much with this as far as like dealing with patients who are either like maintained, have schizophrenia that have their symptoms maintained, like kind of under control and being under maintenance, or have you had people with like new onset psychosis that you've dealt with at all?
I mean, this is going to sound probably odd to a lot of our learners or anybody who's like non-mental health, but I will say that it's more engaging and honestly more challenging to approach a patient who is long-term controlled than someone who's like newly psychotic or like newly, disorganized. Because the hard thing is like, like when you're starting therapy, which I feel like we talk about in school and on tests, is like, okay, well, know about cholesterol, know about your QTC, know about your heart rate and your blood pressure and all of that. But when you actually encountered it in practice and you see like, okay, this guy's, like A1C went to 11 in 4 months, and it makes you like reorient and think like, well, what do we do now? Like, sure, like we know some that are less like likely, but how do you actually manage it once it already happens? And so there are their own sets of guidelines for that, and they're not exactly official, but I do have like a collection that I've made. And I will say that like those patients, the biggest challenge I didn't see coming is that I prepared for one of these patients and I had this beautiful pitch and I pitched it to him and he said, no. I said, what? He's like, no, I like it. I said, okay. But I explained the risks again. He's like, no.
Likes what?
He likes being stable. He likes the drug he's on.
Oh, gotcha.
And he doesn't care about the side effects. He'll work it out. And honestly, there was a part of that I like was really, you're gonna think I'm a jerk. I was really humbled by it. And I thought like,
why would I think you're a jerk?
Well, because I think like only people are like, oh, I was really humbled. But I was. It made me feel like,
you're right. Now I think you're a jerk.
This really is like a 50-50 thing. Like if they're not on board, it doesn't matter.
Yeah.
And like there was nothing I could do to get him on board because he liked being stable more than anything else.
Yeah, of course.
And so that was the end of the story. It was really interesting.
That makes sense.
Yeah.
So as far as like, the different types of symptoms, we have like basically hallucinations where you're seeing like the perceptual abnormalities. It can involve it can be auditory, it can be visual. You may have delusions where you have like these erroneous beliefs. You could have like misinterpretations of reality. You can have patients that have like disorganized, whether it's speech or behavior. And then they have what they call negative symptoms, which is where they have like affective flattening, allergia. What are some other negative symptoms that you've seen, Patrick? Can you think of any off the top of your head?
So like even the ones that aren't acute, like social isolation, withdrawing from family and friends, not communicating with people is a huge one that's usually pretty predictive because it usually is a slope, at least in my experience. I can't say this like I have 50 years of experience, but for the patients who do present acutely, there is usually some warning signs like them not showing up to appointments, like maybe like their wife saying that they don't talk to them anymore, something like that. Aside from those, we've got like, not going outside, like staying home, even if it's like at a detriment to your health. So like not going shopping for groceries, for example, is a good one. Not like showering, not doing the activities of daily life, something that leads to you being non-functional. And this isn't exactly stuff that you'll see in an inpatient psych ward. You will see like the flat affect, the lack of speech and all that. But some of these signs can precede it like a pretty long way. I don't know what I'm leaving out.
I think you got it. And then there's also cognitive symptoms, which they look at a little bit separately, but impaired attention, working memory, executive function can all be impaired as well.
And the other thing that would be, and we're all in the pharmacy side of things, but the other thing that would be really difficult too is also the differential diagnosis as well. Like, is it truly, true schizophrenia that's causing this patient's symptoms? I mean, there's so many different, like, I guess, what's the word, subcategories of that, like schizoaffective disorder. And
and there can be overlapping things too. And I think pharmacists still have to deal with, teasing out what's appropriate because that's going to affect treatment too.
Yeah. And the problem is if you go to like, even like, like a tertiary reference like LexiComp or something, and you look at, let's say, cariprazine or something that's like extremely specific, it'll say, like don't misquote me. It'll say schizophrenia and bipolar, but if someone has schizophrenia bipolar type, for example, you can't like approve that because it's not schizophrenia or bipolar. It's very specific. Mm-hmm. And what I've come to learn is that, like in my experience, whenever I'm reading these notes, the first time you see someone, or the first time a provider sees someone, I should say, that diagnosis is not going to be schizophrenia, PTSD, like MDD or something. It'll say MDD, rule out mood disorder, rule out schizophrenia, rule out substance use disorder. Like it takes a long time. Like I think it's like Cole said, teasing that out and really making sure that you have the diagnosis. Cause there are like questionnaires and stuff, sure. But when you come to like an actual diagnosis, it's something that you really need to be sure of because you are kind of putting a label on that person that could affect their medical life forever.
Well, and also too the non-psychiatric issues. I mean, you could have everything from a brain tumor. There's different endocrine disorders like Addison disease or Cushing syndrome, neurosyphilis, Lyme disease. Like there's all these different things that could potentially cause multiple sclerosis. Even like Wilson's disease, you get a buildup of copper in your system. And there's so many different things that could potentially lead to some of those symptoms that definitely would be a tough diagnostic criteria to meet.
Something that I think, and I won't get on a tangent about this, I promise, but something that I feel like we leave out a lot when we think of psychosis is Parkinson's disease. Because a lot of people say that, like Parkinson's disease, the biggest complication is like the movement disorders. And I would actually argue with that and say it's the progressive neurodegeneration. I want to say like, it's not like a death sentence by any means, obviously. I mean, there are plenty of people who do very well with Parkinson's, but if it goes untreated, the disorganization goes farther and farther and farther. And part of the basic workup for Parkinson's is asking how their mood is, and then asking if someone's with them, how they think it is, and seeing if they match. It's super interesting, but PDP or Parkinson's disease psychosis is very specific and kind of hard to manage if you don't know what it is, if it's just someone who comes in psychotic and you don't know anything else.
That's a good point.
Well, speaking of the EPS stuff, so we've gone through the drugs before, but the first generation antipsychotics are going to be, the high potency ones are going to be more likely to cause EPS and movement disorders. You also have a low potency, which have concomitant anticholinergic, antihistaminic, alpha adrenergic blocking properties that are present, but the first gen antipsychotics are going to block those D2 receptors in the brain, dopamine receptors in the brain. That's primarily their function.
And I got to ask this question too, like, well, why are some of the low potency going to have those other like multitude of adverse effects, whereas the high potency ones are more so, trending towards the EPS as far as the main adverse effect? So if you think about it, like the high potency are obviously going to have higher, activity, higher binding affinity towards the D2 receptors. So you're going to get that activation on the dopamine receptors, and that's what actually causing the EPS in the first place. Whereas if you're not getting as much activity on those receptors, it leaves you more room for the histamine receptors, the 5-HT receptors, the alpha androgenic receptors. So you're going to get more of those other types of adverse effects when it comes to those things, because it's more of a spread out amongst those different types of different receptors. So same thing with like mirtazapine, like low doses, you're going to get sedation.
Mirtazapine is crazy. That's a whole lecture. Mirtazapine is the weirdest drug we have.
Yeah. Well, the low doses, you get like more of the sedation and stuff like that. And then as the doses get higher, because you're getting less binding on the histamine receptors and things, you're going to get more binding on, the actual serotonin and stuff like that. So, it's just one of those things when you think about the side effects, low potency, more spread out, high potency though, that EPS symptoms that can be very debilitating to patients.
Right.
And I'm glad that y'all both brought up the alpha adrenergic part of it, because one of the biggest counseling points, like if you're starting someone on Seroquel for the first time, is like, be careful. You're probably going to be dizzy with this first one. And it's not like, like with losartan or something where you're like, oh, you could be. It's like you probably will until you get used to it. Like you need to watch out for this. And I feel like because there's so many long-term, more serious things that can be overlooked. And I think that if I'm the one taking it, I would want to know that I might pass out the next day.
Sure.
It can definitely be dangerous.
Well, especially since it's taken at night. You get up in the middle of the night and you get that orthostatic drop. Usually anyway. So yeah, that's definitely a good point. And we'll talk more too. I got a chart we can kind of go through that has a lot of the side effects and stuff when you break out the different second generation antipsychotics. But as far as the first generations, Patrick, when you're in practice, like what kind of which first generations do you typically see? I mean, haloperidol probably.
Haloperidol all the time, but haloperidol really it's just for like delirium prevention, hopefully in the ICU and treatment ish. I'm sorry. Yeah, sorry. Is haloperidol?
What about like I can't even talk.
Chlorpromazine.
Chlorpromazine, thank you. Or like fluvenazine or any of those. You see those at all anymore?
Personally, and this might not even be true for what's used today, so please take this with a grain of salt. I've personally only ever seen chlorpromazine, and it's just for chemo nausea.
Okay. Which is the one they use for hiccups off-label? Isn't that chlorpromazine?
I think it's also chlorpromazine.
That is chlorpromazine.
Yeah. That's a weird use.
I have also seen that used for hiccups.
I've seen it as an indication, and I actually thought it was wrong. And I looked I looked silly.
No, I had a guy prescribed it, and sure enough, I checked him out, and he was hiccuping like he was doing it, and it was like it made your stomach hurt to watch him hiccup the way he was.
Oh, I'm so sorry. I'm not laughing.
Yeah.
It's just the word is funny.
I mean, it just seems like you're laughing.
No, I'm coughing.
No,
was unique.
The thing is that he just didn't know about the pickle juice cure. Isn't that what cures hiccups?
Pickle juice.
I'm pretty sure.
I've never heard that.
AJ, have you heard of
AJ,
that?
have you heard of that?
Confirmed.
Oh, okay.
Confirmed.
So that side of the table has heard of pickle juice. This side is
That's confidence.
I've heard of scaring, and that's
Scaring works.
Scaring,
Oh,
or
yeah.
Drinking water upside down and holding your breath or whatever.
Telling someone to try to hiccup. Now, with that, if you have to take a drug for it, I'm sure it's pretty severe.
Yes, his had been going
To
for
be
months.
fair,
It was like
wow.
a long time.
I can't even imagine. That must be debilitating.
Yeah, oh yeah. He said he couldn't sleep, anything.
Oh my gosh, I'm such a jerk. That's awful. That's horrible.
Yeah, I know. It's awful.
So we mentioned EPS, so extrapyramidal symptoms. So we did a whole podcast on tardive dyskinesia at one point, which is kind of, sometimes included in that, but also sometimes kind of talk about separately. But EPS in general, it can be a host of things. It can be Parkinsonism, which is more where you have like combination of like movement abnormalities that are seen in Parkinson's disease, like the bradykinias or the rigidities or tremors. You can have the dystonia, which is where you have like this muscle contraction that happens kind of uncontrollably. You can have the akathisia, which is like this feeling of inner restlessness. And then tardive dyskinesia, which we've talked about more at length, is the stiff, like jerky movements, face and body types of things. So that's the other thing that can be pretty difficult, I think, to differentiate unless you're used to seeing those kind of things. Patrick, have you seen some of that in practice at this point, where you have patients presenting with that?
Yeah, so I actually am now just coming off of my rotation of inpatient psych consults, and we saw a surprising amount of this. Most notably is, I want to say, with Parkinsonism, I was shocked at, like, you read it online, you see like pill rolling. And I mean, the whole time we talked to him, the guy was pill rolling. The whole time. It was like unreal. The stiffness of the joints, absolutely like a very literal thing. When they say like clockwork, I believe they call it. What is it?
Yeah, it's like clockwork
clockwork.
rigidity. I think that's...
Is it called clockwork?
No,
Yeah.
not clockwork. It's well, it's like...
It's something
I know
like
what you're
that.
talking about. I'm describing it, but for anyone who's not watching
Yes.
YouTube, then you know.
It's tick, tick, tick of your arm.
Cole's
I can't
doing the
remember
robot from 85.
It's not clockwork. It's something like clockwork. Someone's going to correct me.
It's TikTok.
It's not TikTok. But
Patrick,
anyway,
I know you're on TikTok.
the most bizarre one to me, and I know that like a lot of people think like, tardive dyskinesia, but the most bizarre to me is akathisia, because it can present as nothing depending on how cogwheel.
Yeah.
Cogwheel. Yeah. Not
Just like clockwork.
Not clockwork makes more sense to me. It's like, whatever.
It's like a ticking clock.
It's like Cole knew what I meant.
What if you're a Rolex and you have more of a sweeping hand?
Cole knew what I meant. But akathisia is, like he described, the feeling of restlessness, most commonly seen with aripiprazole, the only side effect of aripiprazole that is significant. Thank you so much. Pay me and I will advertise for you Abilify. It is the best antipsychotic in terms of tolerability. Anyway.
Literally, ever since I've met Patrick back in
You knew I was gonna bring it
2018,
up.
he can't not talk about Abilify.
It's the
his
best one.
favorite
You
drug.
need to talk to patients who take this drug.
So-
they don't mind.
We've been using it a lot more at our
I
clinic.
bet you have. You're welcome. You are welcome, honestly.
Okay.
So anyway, the akathisia, which
Rick
is the
Salty
only...
Rick Salty called it.
Rick Salty's too expensive.
Well, they want their EPS back.
That's fine. They can have it. The akathisia, which is, again, really the biggest concern that I personally would have with starting someone on aripiprazole, just because it is one of those shorter term EPS side effects. It's not something you would expect to see in years and years and years. It's something that could develop like in a week. And the problem is that depending on the patient, it can look completely different. And because it's just this feeling, and every patient I've talked to who actually has it answers it the same way. It feels like I need to like jump out of my skin. Like it's just absolutely restless. And like they call it like if you look it up, some definitions call it like discomfort, but it's like discomfort because you can't stand staying still. It just like hurts almost. Super interesting. And thankfully, a lot of times just completely reversible once you start something and stop it.
So, and we'll definitely come back to aripiprazole because I'm liking that one more. No thanks to Patrick. I don't want to give him any credit whatsoever. He's already got a big head.
Vast D trial. Thank you so much.
Added to bupropion. We're aware. We all read.
Added to bupropion?
or against bupropion, or the combination. There's 3 arms.
Yeah, there is.
Yeah, I know there was. Yeah, we read too.
There were 3.
Yeah, we read. It's fine.
Switch, augment,
Thinks he's so cool. That trial was like so 2017.
Oh, but it actually was. I'm so impressed.
Dude,
off the top of your head.
It is what it is with
I
me.
am so impressed.
Thank you.
Wow.
It's not a big deal. No, but as far as going back real quick to the first generation antipsychotics, like the reason why we've tried to kind of move away from those is because of the different adverse effects, especially the EPS symptoms with the more higher potency ones. So when it comes to high potency, we're thinking haloperidol, fluphenazine. What's the other one? Thiothixine. That's the other high potency. And then I guess perfenazine is more like intermediate or so. And then like our low potency would be like our chlorpromazine, which I can't pronounce to save my life today.
Is it not haloperidol?
Haloperidol's high.
Am I wrong?
What?
It's the most atypical typical, isn't it?
That would be risperidone.
Yeah.
Am I crazy?
Do I need to talk to your
this is
residency?
so embarrassing. No, it's just
Guys, this is why some people.
You're right, because like droperidol, it is high potency. Proceed.
See, when me and Mike are wrong about something, we don't point it out. We just kind of.
Yeah, this is like almost a whole minute. Yeah, feels like to me anyway.
It should.
I feel like last time I was here, I missed something elementary too, and I was really embarrassed about that too.
That's all right.
Yeah,
We've done it 1,000 times, so it's no big deal.
Yeah, okay.
Literally.
You're making it a big
Yeah, we
deal.
just let other people point it out.
Yeah. Usually in the comments section on iTunes.
Do you actually get comments correcting you?
Not usually
No.
correcting. It's usually something that we can't correct. Like, I heard your voice.
Oh, sorry.
Thank
look
you.
of your face.
Thank you, kind sir. Really appreciate the support.
You need a better mic.
Yeah, it's
I
fine.
hate your
Yeah, I know.
voice.
I was like, I'll just try to fix whatever that is that I can do to fix that.
You have a bad name.
I do. Yeah, I don't like it either. I don't know what you want me to do. Talk to my parents. No, so that first generation, obviously a lot of bigger side effect profile, things like that. So second generation came out. The idea of those, they also call them the atypical antipsychotics. That's second generation. So typical being first, atypical being second. So those are going to have relatively lower risk of EPS. The risk of like specifically tardive dyskinesia is a lot lower with those typically. And then also some of the other, depending on the agent, some of the other adverse effects can be lower as well, sometimes higher depending on the agent. We'll kind of talk through some of those.
Right.
But one of the big ones that I think got a lot more attention in like the newer set of guidelines, the 2020 guidelines, was the Clozapine. Patrick, you see that much used in clinic?
I mean, much might be an overstatement, but I also do like follow all the Clozapine patients. So from my perspective, yes. I would say like for whom it is used, it's shocking the turnaround that some people will have. The only condition being like staying on it. But like, honestly, for all the monitoring you have to do, it is, I think the last time that we did this, you mentioned that like, if you do the monitoring, it's fine or something like that. And I have to agree, because I used to not think that. I was like, well, you have to look at like an ANC, like that's scary. But these patients like stable. And then when they're not, you just hold off, let them recover. Stable. It's crazy.
Yeah, it works great. And to those monitoring parameters, so the big concern is agranulocytosis, which
Right, yeah, sorry.
is a significant decrease in white blood cells, primarily neutrophils. So there's significant monitoring. So you think of monitoring that might be cumbersome. You think of warfarin or something with monthly monitoring. When you first start on Clozapine, you have to have your ANC checked weekly for the first 6 months, every other week for the second 6 months. So for the first year, they're making very significant amounts of trips to get their blood checked. After that, it's monthly. So every 4 weeks for a year, and then however long they're on it, they have to have their ANC checked and monitored. Mild neutropenia would be an ANC 1,000 to 1,500, moderate 500 to 1,000, and severe would be anything less than 500.
You know, something fascinating, and so first of all, your monitoring is absolutely right. I mean, I wanted to say while you were listing them, like I am surprised, and not because I like don't give patients credit, but it's because I sympathize. Like I am surprised that every week for that long that you go get your blood drawn, you know, but it does work out. And more notably in COVID, some of those labs have been deferred,
right?
Because these patients are so stable. And I've been hearing about some people like trying to do a retrospective trial to see if that makes a difference.
Yeah.
And if it doesn't, if you're actually getting every other month monitoring, I mean, what if that starts contributing to changing monitoring? I mean, that would be crazy.
That would be
Right,
crazy.
because it's an FDA REMS program. That's why they have to do this. That's why pharmacies who dispense it have to be certified to dispense it, and then doctors who prescribe it have to be certified to prescribe it. So it's this whole thing. So when COVID happened, the FDA put out a release back in March, I think it was March 22nd, basically saying that if need be, if the risk outweighed the benefits, they could forego testing for a period of time or whatever, or at least do more infrequent testing, which is a big deal because, similar to iPledge or any other REMS program, it's very serious and you can't dispense the no blood, no drug. Is that what they say or whatever? So yeah, that's very interesting what COVID had done to the treatment.
And it's typically started off fairly low dose and then slowly titrated up. One, because of the orthostatic hypotension, the bradycardia, syncope, all that stuff. And it also can lower your seizure threshold as well if you go too quickly. The other kind of adverse effects we're typically thinking about is like the weight gain potential and maybe even affecting your lipid levels, so inducing some dyslipidemia. But yeah, the orthostatic hypotension, kind of like we talked about earlier, Patrick, with like Seroquel, is definitely a concern with Clozapine, at least something to let patients be aware of, not necessarily a concern. But if you have a patient that's struggling with, some of the weight and some of the, like maybe the metabolic syndrome type symptoms where their lipid panel's a little off, at least, giving them some supplemental meds if possible, or if needed, maybe some diet, education, things like that, because I would argue that controlling their symptoms is probably more important than worrying about the weight gain, but still something to think about because you don't want to add a bunch of comorbidities because patients, doesn't have a healthy balance, I guess, throughout those other health conditions and whatnot.
I would say if it's available to you in whatever practice setting that you're in, if you are starting Clozapine in a patient and you have like any reason to suspect that it might not be safe, just please check like a baseline ECG. It's like in the monitoring parameters, but it's not even like it's like the heaviest hitter. Don't get me wrong, it's heavy in terms of like prolonging your QTC and risking torsades, but just keeping in mind that most of these patients don't stay at like the 100 BID. Like over time, this will be a pretty significant dose for many patients, and just trying to get ahead of that so that you at least have a baseline for the future.
Oh, and especially, I guess, if they have other, potential drugs that can prolong the QT interval or low MAG levels, a history of low MAG, something like that.
Absolutely.
Something to
Age,
consider.
chronic illness, so many things.
And there's a few of those second generations that we do have to worry about that with.
Of course.
And like I said, we've already discussed this before in a previous episode, so we won't go through every single one of these agents.
What's not one of them?
What, as far as QT?
Yeah.
Aripiprazole?
Yeah, good answer. It is aripiprazole.
I'm going to fight Patrick in about 3 seconds.
Potentially even shortening.
So is quetiapine. So is risperidone. Should I keep going? Latuda, several others besides stinking-piprazole. This guy. No, but we went through a lot of these, but I guess let's touch on just some of the different adverse effects to keep in mind. I will definitely say Patrick is 100% right, as much as it absolutely just pains me to say.
I make it hard to admit.
It's extremely. But aripiprazole does seem to have a very low side effect profile comparatively. And in fact, there's certain tests on, or certain questions on, like, I don't know, certain board certifications and things like that may say, like, give you a whole list of different comorbidities and things like that, and then ask, which antipsychotic would this patient be best suited for? And aripiprazole seems to be the answer on every single one of them. Because I was going through and I was like, literally, as I was taking my ambulatory care boards, I was like, doggone it, Patrick. I was literally angry at him, thinking about him.
That's awesome. I'm glad.
Yeah.
You knew.
Yeah. Well, it wasn't just from you, but... No, but as far as like the main things, we said weight gain with Clozapine, and we'll come back to like where Clozapine kind of fits in a minute. But other ones to think about, olanzapine is the really bad one when it comes to any of the metabolic syndrome symptoms, diabetes. Mm-hmm. For us at our clinic, it was a big deal because that was one of our cheaper antipsychotics for a while. Now we have Abilify and some other ones, but that a lot of patients got put on that because we had like a direct relief where we could give it for free and stuff like that. But these patients also had diabetes, and it was like causing their diabetes to be much harder to control, especially at like higher doses and whatnot, but increases weight gain, diet glucose control, dyslipidemia, all that stuff. And then it also can increase sedation as well, or cause sedation rather. But olanzapine and Clozapine are probably the biggest as far as weight gain goes. Some of the ones that have probably the highest instance of dyslipidemia is probably clozapine's the highest, and olanzapine as well. So metabolic syndrome, those are the two you should always be thinking about as far as that, especially when it comes to the blood sugar, the blood glucose control. Olanzapine's always a culprit. And as far as like sedation, again, olanzapine. Quetiapine is another one.
Yeah.
So Seroquel. And then clozapine again. So we're trying to see a pattern here. But if you look at like which ones have fairly low adverse effects in all those areas, so the main things are the metabolic syndrome symptoms, so like weight gain, diabetes, dyslipidemia, and then things like cardiac issues, whether it's orthostatic hypotension or QTc prolongation, and then also sedation is the other big category to kind of focus on. One of the ones that have the least amount of those or risk of those things happening, aripiprazole, like we said, Vraylar is pretty low on most of them. Maybe orthostatic hypotension, but other than that, Vraylar's fairly low. Latuda is another low one. It's got like moderate sedation, and akathisia is another potential risk with that one, just like it is with aripiprazole. There's got to be a mechanism there. Like when you have low risk of those other things going on, maybe it's got higher binding affinity to D2. Is that what it is? I'm just making this up in real time.
I mean, I think that's the understanding. I guess I can't say for sure.
I never looked into it, so if it's the common understanding, then sorry.
Okay, well, I mean,
I just never thought about it.
I guess I should know too.
I mean, we were hoping, but that's fine.
All right, pause the podcast, look this up, and come back and hit play.
No.
Pause the podcast. Yeah, right. Like that's never happened for anything.
Is there a pause button on this?
Yes. I thought it was just play and stop.
Stop your workout.
That's what I was thinking. Ziprasidone is one that we have to worry about QT prolongation.
Oh my gosh, it's actually like nuts too. I mean okay.
Yeah, it's so excited.
Sorry. It's just because
you're very passionate. It's good.
I'm passionate about like anything I've had to answer a drug info question on, because it means that I've really like poured over it and like learned the answer. But like ziprasidone is like nasty. And the thing is, it actually like in practice usually doesn't. And my theory is that that's because people don't eat a meal with it and that they don't get the full thing. And that's just my theory. That's because it's a conspiracy for sure. Don't take that as a fact. But like people, when they do have QTc prolongation, it goes like beyond the pale. Like we're talking about like over 50 milliseconds. It's like nuts.
So when I was fourth year, I won't even say what rotation I was. I was on one of my acute care rotations.
Sure.
I was on rounds, and we had rounds like in a like not actually in the actual patient's rooms. We were like kind of meeting beforehand, and it was just me. I was the only. My preceptor was handling another issue at the time, and I was just sitting in the room listening to rounds, and it was nothing but there was an attending and like 4 residents and me, and I was like, I finally had my moment. Why I even opened my mouth, I don't know. But like I saw they were like going through all the different patient stuff, and one patient was on Geodon, and I was like kind of like raised my hand. I was like, does anybody know if like he ate? Like if he's getting it with a meal. I said that. Well, they all looked at me and they're like, what? Because his stomach's upset, and they all cracked up laughing at me. And I'm sitting there, and I was like, and I was like, you know me, I don't like getting laughed at very well. And so I was like a little bit irritated. I was like, no, not because, and I probably in hindsight I was probably pretty rude, but I was like, no, not because his stomach hurts, because he has to be taken with like a 500 calorie or more meal, or it's not going to be effective and cause QT prolongation and all this. And they were like, oh. They're like, I guess we should check the nursing notes. And I was like, my preceptor was like, yeah, he's spot on. Why y'all laughing at him?
Gosh.
I was so mad. I was like, awful. I finally had a moment, and they just all crack up laughing at me like I'm an idiot.
I hate the fact that they laughed. That's the worst part. Is that they're all on the same page.
It's fine because they all knew I was right later. So redemption.
It ended up fine.
Yeah,
you were vindicated,
and it's fine. And then and honestly, it's a chip on my shoulder I've carried to this day. So
yeah, I definitely don't remember all of their names.
It's the reason I've done everything I do.
I got a little notebook. I'm just waiting to take them down.
He knows all their names,
where they live.
When you get the Platinum Podcast Award for
it was February 2015. It's not like I'm remembering.
It doesn't matter.
Take it with food.
Hold me back, Cole.
For that, also lorazepam. I don't want to go too far past it. It's the same deal, just less food.
Yeah. The lorazepam, surprising. Have you seen this where they showed that it's like one of the only drugs that's been shown when you have a patient that has depression with mixed features, like specifically where they haven't quite met the criteria for hypomania, So you couldn't push them into the category.
Bipolar depression with mixed features.
So actual major depression disorder with mixed features.
Okay, sorry.
So not
Yeah,
quite bipolar.
I misunderstood. Okay.
So that drug, the Latuda monotherapy, is the only drug that's been shown to be that's been studied in that particular patient, category that's been shown to be efficacious. So the number needed to treat was 3, and that David Osler's group out of Harvard Medical that wrote that paper. I don't even know why. Now Patrick's laughing at me.
Well, it's just you're 3.
It was.
Low.
That's pretty low.
It's low.
Name one other study that has a number needed to treat of 3.
I don't know.
Name one. Go.
I don't know.
You can't. That's right.
Cole?
No, I got nothing.
Yeah,
Okay.
that's because it doesn't exist.
Okay.
Patrick, get out of here.
I was waiting for UKPDS.
Yeah.
I'm pretty sure that was not 3.
Not even close.
Not even close. 20 years later, they
Metformin to decrease blood sugar. Number needed to treat of 1.
We're also going to get blasted for this for going way off topic
Oh, yeah,
50
I know.
times. Cole's brother's
Well,
not going to be
Patrick's
happy. Yeah.
Yeah. I'm gonna scold y'all after the podcast.
Man, I'm so glad y'all have a scapegoat this week.
Yeah, that's true. Thank God Patrick's here. I'm going to put it in the show notes. Disclaimer. We went off the rails because of Patrick
Wow. Here's his address.
and his phone number.
Okay.
Troll him like crazy. What about Caplyta? Have you seen that at all?
I'm so sorry. What's Caplyta? I don't know brand names at all.
Oh boy.
You're gonna make me ask.
What's the brand? It's a
Lumateperone.
Lumateperone.
Oh my gosh!
Thank
Just
you.
say Lumateperone. So actually, the reason I don't know that one is
Don't.
because
First of all, you didn't know the brand name, which
First
is
of
all
all-
over the commercials.
First of all, I've been following it since it was a number. Okay, so I
okay.
know it much better than you. But
well, we'll see.
I remember I texted you about it, I think, and I said, "This is gonna change bipolar." You were like, "Okay."
Probably have the text here. Let me go ahead and pull it up.
Don't look it up. It started off very hopeful. Lumateperone was known as being very, very hopeful for not even causing EPS while controlling psychosis, because the thought was that its selectivity was so much more specific than every other antipsychotic that we have that it could selectively inhibit the dopamine receptors that we're looking for when we're talking about actually preventing psychosis and delusions and all that, but not the ones that are associated with EPS. And so it started off very promising. Then it didn't even finish one of its trials because it was so bad. And I really don't know what happened. But after that, they bounced back a little bit. Now they're a real drug. But I thought it was going to change everything. I thought we were going to have new antipsychotics forever. But anyway.
Well, because it's a partial agonist at D2 presynaptically and then antagonist postsynaptically. Correct?
That
I know
sounds
that's
right.
correct. 'Cause I'm looking at it.
Okay. It sounds
No, I
right
just
because I don't
wanted to-
have anything in front of me.
Right.
For y'all listening at home.
No, I just wanted to point out that Patrick maybe doesn't know as well as he thinks he does.
I just explained.
Kinda.
Didn't say the numbers.
Yeah, no, I mean, most of our listeners like people to be thorough, but that's fine.
Oh, well, thanks for doing that then.
You're welcome. Thank God I'm here.
With the computer. Anyway.
So, yeah. So as far as that's kind of like a quick overview. We can, if you guys are curious, I have a couple cool slides I can send y'all if you really want more information on the different side effects and what has the risk and likelihood of them happening. But
I will say there's one that we haven't mentioned before we move on, and that's prolactinemia or hyperprolactinemia, I guess you could say. A big concern with all the typicals and risperidone.
Are you quizzing me right now?
No, it's because you corrected
He
me
does like
earlier
to quiz
about
you during
risperidone.
live on podcast. There's a
No,
quiz
it's
for my-
because I'm making fun of
it's-
myself here because I
yeah,
didn't know it earlier.
Bring it on.
and I'm just saying the hyperprolactinemia is kind of hard because it's almost like you just have to switch after that. There's no real coming back from it. There's no bounce back of decreasing the dose. You just have to try another agent that hopefully doesn't have that concern with it. Super interesting.
Is it primarily just patient complaint, so they want to switch, or is there any big concerns with them?
Well, I mean, it's uncomfortable, trying to remember the main symptoms.
Well, I'm
of
thinking about the guy who was like, no, I'm okay with my symptoms. I want my mood to be better. Can you be like, okay, well, as long as you're okay with these symptoms, we'll just keep rolling.
Well, so actually, in my experience, when people get labs, and again, the prolactin labs, are not often at all. I mean, we're talking about I'll be honest, my only experience is with men, so we have the obvious
Gynecomastia.
the obvious side effect, and that is intolerable. But I will also say that when providers have had a high prolactin level, they have also like mandated a switch. So I would say either or.
Yeah.
It really depends.
But probably switch.
Well, I guess in females, if I remember correctly, it can cause like amenorrhea.
Yeah.
Oh, absolutely. Yeah, and that's
Yeah.
I would call that intolerable.
Yeah.
Or just give them bromocriptine, call it a day.
Let's not
Add on another drug to treat a side effect
Just
of one
saying.
drug.
Just saying.
give them
Just-
two.
Hey,
Hashtag pharmacist.
AJ, we got options over here, dude. Don't worry about it. If you need answers, come to me, not Patrick.
Give them 2 units of blood. Treated.
So let's talk through some of these. Now that we're just completely off the rails, let's talk about some of these guidelines that the American Psychiatric Association put in on paper in 2020.
Well, before we move on, I actually do.
Please,
I want to include AJ in this. Is
AJ.
What's your understanding of like where we are, like with like mental health treatment? Like when we say like antipsychotic, do you like know what we're talking about? Are we like going too fast? Because I can't remember if I knew.
You mean
feel
from
like I
a
knew what they
P1,
were
from a
as
P1 perspective?
Yeah.
Just like, what do you know about it?
Yeah.
So I feel like I've got a greater understanding than the general population
Okay.
of the United States about the disease state. But just there's a lot of questions for beginning medical experts, like what even do we allow to be treatable? When do
Of
people
course.
come in and say, hey, we've diagnosed you with schizophrenia, but it's at the point where if it's not bothering you, we're not going to try to even go
Yeah.
down that road. There's a lot of questions and things that people like me have.
That's pretty wise. Consider mental health. Have some empathy for your patients.
Yeah.
And even though he sounds like he's being sarcastic, he's
not-
actually being.
Did that sound
serious.
sarcastic?
I'm not slightly. I'm just saying people who don't know you
bit.
maybe have taken it that way.
It was
But
wise for a P1 to
he
say.
is being serious. That's how he sounds sincere, believe it or not.
Well, I appreciate you making that disclaimer.
Yeah, you're welcome. No, but like I said, that even gets confusing for me. I would say, like, just not working in this space, and dealing with, this a lot. That would be a hard thing for even me to be able to jump in and just be like, all right, got this.
But that's a good segue because part of the guideline, they're basically saying if the patient has been diagnosed with schizophrenia, they do want them to be treated with an antipsychotic pretty much across the board.
So when was the last time we had these guidelines? 2004?
No.
It's been a heck of a long time, right?
Really? Is that
Has it
long?
been that long?
For APA?
Let's
I could be wrong.
see.
I think it's been a while.
I feel like they mentioned it in the guidelines of when they actually. Yeah, 2004.
Yeah.
They
Crazy.
No, yeah, you're right. 2004.
Yeah, that's a long time.
Because the American, they did the full practice guidelines in 2004, and they did like a guideline watch in 2009.
Yeah, that's right. They did. That's right.
But still, it's a long time ago.
They didn't change a whole lot.
No.
Clozapine's more prominent.
That's
I
the
guess.
That's the big thing.
Yeah.
And I feel like they did that, and then they also really specified like what treatment options they want if the patient does have a specific type of EPS. They did kind of go into more detail about that as well.
I mean, there's a lot of new drugs that have come out since 2004, so I'm sure they just plug those in there. But as far as, first line therapies, yeah, if it's treatment resistant, consider clozapine more than you would have before. High risk for suicide, aggressive behavior, consider clozapine more than you have been before. So just a big emphasis on clozapine.
And then also they talk about the long-acting injectables, especially if the patient has a history of poor adherence or if you're not sure if they're going to be adherent or not, the long-acting injectables is definitely the way to go.
Yeah.
As long as you can get access to it, which I feel like it's fairly easy to get those medications, even if patient doesn't have insurance and things like that. You can find ways to get them, whether it's through the drug company and whatnot.
Right. The main or adherence issue would be going in and having it injected unless they did it themselves or whatever,
And I'm just talking from a cost standpoint because they can be expensive. But I know like some of the drug companies will give you, if you're a psych doc, will give you access to a couple samples like every month or something like that, because we've done that a few times at our clinic.
Oh, wow.
So there are definitely ways. That's one thing I will say about working in a place like Feder that I've learned a lot about, like how to find some of these medications. Even brand name certain medications that I can get for free for patients. There's a lot of programs out there that I had no idea existed before.
Right.
So that's been super helpful. We should do an episode one of these days on that.
Like options.
Yeah.
Yeah. We should do
Or just like where to find.
Yeah, because we know a lot of
patient
stuff in
assistance.
South Carolina, but it'd be interesting to get a countrywide list, of ways that patients can get free medication.
Yeah. There's definitely some good options.
Yeah.
So basically those things, and then like Cole was saying, clozapine, they just kind of they talked about that several times, and that's a much more, we need to keep that in consideration maybe more frequently than we were before. As far as some of the EPS, adverse effects that they want to deal with, they give recommendations on how to treat those and handle those. So if a patient is having dystonia, like acute dystonia associated with their medication, they recommend treating with an anticholinergic, so like benztropine. If the patient is having Parkinsonism associated with their therapy, either lowering the dose, switching to another antipsychotic medication, or you can also use an anticholinergic as well, like a benztropine, to kind of treat those symptoms.
I'm going to say a similar thing with akathisia. Lower the dose, switch to another, or add a benzo, or add propranolol. And I guess from the mechanism, you kind of assume why they would want to do that.
What about TD, Patrick, your favorite drugs?
They are my favorite drugs. I got them approved for you.
I know.
I actually don't even
that.
know if that, did that last? Were they actually approved for you?
So we were having issues with, because you got the Ingrezza, right?
Yeah,
the
like
valbenazine.
the
A couple people that we've gone and done since then have been the Austedo, just because it's been easier to get.
I totally believe that. I think that's true universally.
And it sucks because it's twice daily instead of once daily.
Yeah.
But it's been way easier to deal. For whatever reason, getting the med is so much easier.
I remember when I was with you, and so sorry, what we're talking about is like deutetrabenazine, tetrabenazine, valbenazine are like your three mainstays of like your VMAT2 inhibitors, your vesicular monoamine transport 2 inhibitors. And the really big pearl here, if you learn nothing else about them, is that you have to keep taking it. It will stop working. I've seen this in practice several times where people go from absolutely controlled to they say, I don't need it anymore, and they are back at baseline or worse. I mean, it is absolutely imperative that you keep taking it.
That's so interesting. So at this point, it looks like it's lifetime.
I don't want to misspeak, but if you look at the actual, I want to say it's the valbenazine trial that got it approved, they've got these amazing graphics that really show you visually what I'm talking about. So I encourage you to look that up. They've got these beautiful images. You can probably see it on Google Images easily.
I know what you're talking about.
Because they're so good. Mm-hmm. And what you see is like, I mean, I think that they only measured them at first. Gosh, I don't want to misspeak. It's either like 52 or 96 weeks. And when they looked at them the first time, you see this like complete control. And then once they cut it off, it goes the other direction sharply. Like within a few weeks, it's back to baseline again or worse. So like, unfortunately, it might be. It's definitely based on the patient's goals. It's not like it's really going to be based on their functional life and how severe it is, unfortunately.
Man, those drug companies have to be happy from a financial standpoint because they're going to be taking it for years and years and years.
I guess so.
You know how they think.
They are. Yeah.
Hopefully, it's one of those things that we'll eventually find an actual cure.
A cure.
Because at least valbenazine and the Austedo, both of those have been at least better agents than we had before. But still got a long way to go.
But that was great because before that there was nothing.
Yeah.
I mean that's great.
I think the big thing is trying to catch TD before it even before it has a chance to stick it and then try
prevention
to
would be the
try a different
goal.
drug.
Yes.
Yeah. But which is one of the reasons why I think we've a lot of times gotten away from our first gen antipsychotics.
Mm-hmm. Yeah, we did do a whole episode on akathisia and tardive on EPS and TD, didn't we?
It was just TD, I think.
It was just TD.
Mm-hmm.
Wow, look at us.
Look at us go.
Who would have thought?
Not me.
Nice.
Did we leave anything out, Patrick? That's pertinent. You can think of?
Oh, is that everything?
I don't know.
For today, at least.
Oh, well, I mean, I don't want to.
I mean, obviously, we're gonna have to do this one again. Once everybody forgets about it.
We're gonna do a review of the 2020 guidelines in 2021. I will say that there are several things that, like, if we're talking about like schizophrenia, then like we could talk about like the other stuff involved, like the actual like non-pharmacotherapy. But I understand that like pharmacotherapy is like the focus. But I will say that like non-schizophrenia psychosis is like definitely a thing with like treatment-resistant severe depression, with bipolar, especially like schizoaffective or something along those lines. And you don't always like. I want to like say for someone listening, if they aren't that familiar with schizophrenia or these mental health states, antipsychotics should almost never be your first move unless we're talking about true like schizophrenia and like actual like dysfunction because of it. Like if someone has treatment-resistant depression, while like I'm referencing with like VAS-D, while antipsychotics are some of the most effective augmentation agents you can have, and especially if there's psychosis present, of course. But if it's just true treatment-resistant depression, there are many other options, and sometimes treating the mood can resolve that psychosis. And it depends on the degree, of course. I don't want to be irresponsible here and say don't treat the psychosis, but but I also don't want to say if your patient has something that seems like a delusion, maybe it's not time for an antipsychotic. It might be time for a referral, for example, and let a psychiatrist diagnose them with something first before you actually pursue it.
And I think too, the way I think about it too, when it comes to like depression, if you need to augment, if the patient has depression and also has like anxious distress on top of it, like they're dealing with anxiety and depression, that's really where I start to automatically think like maybe adding Abilify as my augmenter.
Yeah, and honestly, I mean, we say it like as a joke, but Abilify 5, it's not benign, but it sure is better than the alternatives.
Yeah.
As far as tolerability goes. And if it works, then it works. The only concern that we have is like response really at that point.
Yeah. But there you go.
There you go.
Now we've covered all of it. Nothing left.
That's it. We're done. Patrick, man, thanks for coming over here. I know you've spent 10 hours working today, so I appreciate you taking the time.
11.
Always a pleasure.
Thanks so much.
11. Oh, my gosh. That's it. I'm done. I'm going to choke him out when we get off here. Patrick, I love you, buddy. Always a pleasure.
Thanks for having me.
AJ, man, thanks for coming.
Thanks for having me.
I know I saw you at work today, too, so I'm glad you, who needs to study for finals, right? You're with us.
He is studying for finals.
Good enough.
I mean, you got to have psych in there somewhere, right?
Sure. Probably not honest
Probably
finals.
not.
When are your
Probably not.
finals?
Tomorrow.
Oh, nice.
Stop, really?
Wow.
Yeah.
Wow. That's confidence.
That's dude.
Yeah.
That's why I like him.
Okay.
He's like, finals? give me them
wasn't
all right
like
now.
that.
Yeah, he was. Exactly what he said.
Didn't blow it off.
He did. He's going to get A's like crazy. It's just what he is. It's what he does. AJ's the man.
They don't call him AJ. Okay. No, forget it.
Thank you, Patrick.
Thanks. Cut me off.
Please. All right, you guys. Thank you so much for listening. I know that episode was a little bit more random than we normally do, but that's just because I like hanging out with Patrick and going off script with him. But it is what it is. I can't help it. Patrick's always fun to have him around. But thank you guys so much for listening. If you do like the podcast, make sure you subscribe on whatever platforms you like. If you want to leave a nice comment on iTunes rather, we like that. That's cool. If you want to leave a mean one, I guess that's fine too.
Yeah, reference U-Tunes.
Yeah. If you want to leave a bad comment, leave it on Patrick's Facebook page, please. But thank you guys so much for listening. Thank you guys also so much for those of you who have joined the Patreon account. Like, that means the world to us. That's helped us out a ton. I'm shocked that so many people have supported us on there. It's going to definitely help us keep making the podcast better, adding equipment and things like that. So I really appreciate that as well. Hope those are enjoyable. And if you have any questions or concerns or comments or anything like that, please reach out to us on any of the social media platforms. Our emails will be in the show notes. And then I'll include all of Patrick's information too, so you can get in touch with him immediately. And we'll see you next time. Take it easy.